Hi, I'm David Poe from Clinical Edge. Welcome to this week's 5-minute Physio Tip on cervical spine manual therapy. Is it evidence-based? So as physios, we want to be evidence-based in our assessment and treatment. And so the question comes up when we have a patient that comes in with neck pain, should we be providing manual therapy? Is that evidence-based? Or should we just be providing exercises for them?
So now I want to walk you through those studies that looked at the effects of mobilisation compared to a control. So here we go, we've got the Cochrane review. This was covering manipulation and mobilisation for neck pain, contrasted again against an inactive control or another active treatment. And this was by Anita Gross and colleagues in 2015. If we scroll down to our page that looks at cervical manipulation versus another active control in the Cochrane summary, this is where some of the interesting stuff comes in. We're going to look at this, then we're going to look at the actual studies that were performed, so we're going to understand what the effects are that we're observing here. So it says when you compare cervical manipulation versus another active treatment, it says for acute and chronic neck pain, multiple sessions of cervical manipulation, and that was using 2 trials with 446 participants that were moderate to high quality, had similar changes in pain, function, quality of life, and patient satisfaction when compared with multiple sessions of cervical mobilisation at immediate and short-term and intermediate follow-up. All right, so they're the same, manipulation and mobilisation. What do we know about the effects of manipulation? So for acute and subacute neck pain, multiple sessions of cervical manipulation were more effective than medication in improving pain and function at immediate and long-term follow-up, and they were in 2 trials, both with close to 182 participants. So we're looking at equal effect of manipulation and mobilisation and a decent effect of manipulation compared to medication. So that's looking at it indirectly. Now if we come down here looking at the exact thing of mobilisation versus an inactive control. So this is when mobilisation was performed as a standalone intervention. That's all they did. There was 2 trials with 57 participants that were from very low to low quality, and they found that it might not reduce pain more than an inactive control. Now we're going to look at those exact studies in a minute to figure out what's going on here. So coming down here to the plain language summary of the Cochrane review, it said no high quality evidence was found, so uncertainty about the effectiveness of mobilisation or manipulation for neck pain remains. They said there's lots of challenges. For example, the number of participants in most trials was small, and the included studies were low or very low quality, and evidence on the optimum dosage was limited. So we're not sure. The evidence is unclear. So let's have a look down here at these studies. So when we compare mobilisation versus control, here's our 2 studies. We've got a single session of intermediate post-treatment results, and that was by Sterling in 2010, and that was showing no real effect. And then the second study was Bitterly in 1977. So this is a pretty old study. This is the most recent one, Sterling, that we're focusing whether mobilisation is an effective treatment on. So now let's look at that study. And here it is. So that study is by Michelle Sterling. It's called Cervical Lateral Glide Increases Nociceptive Flexion Reflex Threshold, but not pressure or thermal pain thresholds in chronic whiplash associated disorders, a pilot randomized controls trial. So basically, if we sum this up, this study looked at the immediate effects of cervical spine manual therapy technique on measures of central hyperexcitability. They used 39 participants with chronic whiplash-associated disorder that were randomly assigned to a cervical manual therapy technique of a lateral glide or just manual contact intervention. So this is basically our population that we're looking at. We're looking at chronic whiplash-associated disorders. Now, if ever there was a population that weren't going to respond to manual therapy, it's this population. So let's have a look here. What they said, chronic whiplash is heterogeneous with a subgroup of patients presenting with moderate to high levels of pain. So we know that's how they come in, high levels of pain and disability and widespread hypersensitivity to mechanical and cold stimuli. Now, the thing with anyone that's got hypersensitivity to mechanical and cold stimuli is they invariably, very rarely respond well to manual therapy. If you had to pick your patients that are not going to respond, it's those that are sensitive to cold. So we're looking at a population not very likely to respond. So they did say that manual therapy applied to the cervical spine has been shown to elicit widespread hypoalgesia, which is decreased sensitivity to painful stimuli in both asymptomatic and patient populations. And they cited a number of studies here from Vincenzino and Capitas. Now, if we come down to look at what actually happened in that study, they had these 39 participants that were 18 to 65, and the population is a really important thing to look at when you're analysing these studies. It's going to tell you really who the study applies to. You can sometimes extrapolate from the populations, but realistically, it only applies to the people that are studied. So we've got 18 to 65-year-olds with neck pain from a motor vehicle crash, greater than 3 months duration of pain, classifiable as grade 2 whiplash-associated disorder. Now, we don't have time to go into the grades of whiplash-associated disorder at the moment, but needless to say, you're looking at chronic whiplash pain. So when we look at the treatment that this population received, the spinal manual therapy group received 3 sets of 1-minute cervical lateral glides away from the nominated site of pain with 1 minute rest between sets at C5-6. Now that's fantastic. I'm unsure exactly why they chose C5-6. I mean, C5-6 can often be really helpful for cervical spine patients, but that you can't just go, I'm going to just mobilise C5-6 and expect that you're going to have any sort of result in your cervical spine pain patients. Really, it's based around your clinical reasoning and also your objective findings as you're assessing the person's neck. So now it's starting to come together, this picture, isn't it? Because you've got a group of people that are unlikely to respond to pain. They've got chronic neck pain. They've got sensitivity to hypoalgesia to cold, not likely to respond. They've just chosen C5-6 for no real reason other than that's a standard approach. So it's probably no wonder they didn't have much of an effect. Now, when you look at the manual contact group, this was the control, they put hand placement and positioning, the same as the treatment, so around the C5-6, but didn't perform the neck movement, so no lateral glides. Yep, that's a good control. Both conditions were pain-free, so that was good. So we come down a bit further to part of the discussion, and what they've said is that chronic whiplash demonstrates features suggestive of a neuropathic-like condition that are not so apparent in idiopathic or your regular types of neck pain. So might show different responses to manual interventions. Yeah, that makes sense. You're looking at a very, very different group of people in a chronic whiplash-associated disorder with just using a very non-specific technique and not relying on any of your objective findings to identify what's going on, and you're really going to get a very different result in that. So that's the research that's out there at the moment, looking at the effect of mobilisation compared to no treatment. So if someone says to you that there is no evidence for manual therapy in the cervical spine or mobilisation, now you're educated on what that research is that says that there's no effect. And now we need to understand when manual therapy is supported in your treatment and when there is evidence for performing manual therapy and when there's not. So one thing I want to make really clear is that I'm not having a go at the authors of this study. I think they've done a great job of comparing the effects of mobilisation to control in this particular population of chronic whiplash disorders. What we know is that manual therapy and mobilisation is not indicated in this particular population. What I am saying is that the carryover or the extrapolation from this population to your normal acute and subacute neck pain is not there. So I want to make that really clear that that's what the evidence says right now.
So when it comes to manual therapy, you want to have really good support for actually performing your manual therapy so that you are being evidence-based in what you do. So if your patient comes in, they've got pain and restriction in their range of movement, they've got mechanical neck pain, then you want to be really sensitive and really specific in your assessment of the cervical spine and thoracic spine so that you can identify any impairments that the patient's got that might be contributing to their problem. So if you've noticed that as you're performing it, you identify a particular point in range where your patient has pain, you identify their pain levels, you're really sensitive and specific in your assessment, and you can immediately change their pain and range of movement objectively and subjectively. You then have evidence for performing manual therapy in that patient. So if you can't get an immediate change in the person's pain and range of movement, you don't have evidence for doing manual therapy, and then it's time to look at the other things that might be involved in their pain, such as their endurance, their strength, their motor control, and all the other aspects that can contribute to someone's neck pain. So, in summary, if you can identify that someone has mechanical neck pain, you've identified range of movement and pain levels at that point in range where they get pain, you can immediately change that pain and range of movement with your manual therapy. You have evidence for performing manual therapy on that patient, and you are being evidence-based in your assessment and treatment. If not, it's time to move on, and if you can't get that immediate change, performing another treatment is what the evidence will tell you to do. So I hope you've enjoyed today's 5-minute physio tip. If you've found us anywhere else but on our blog at clinicaledge.co, head on over there, check out all our other resources for you, and I'll catch you on another episode.